One. Please start, sir. We are live.
Hello, good evening, everyone. And it's a great pleasure to welcome you all for this exciting webinar, Recent Updates in Medical Oncology 2024. I think this edition is focused on the treatment and management of lung cancer primarily. Without wasting much time, it's a pleasure to invite the convener of this meeting, Dr. Kapil Goyal. Sir is a consultant medical oncologist at the prestigious Rajiv Gandhi Cancer Institute at New Delhi. So once again, good evening and very warm welcome to everyone. I request Dr. Kapil to start the proceedings, please.
Uh, Good evening, everyone. Thank you so much for the warm introduction. As we know that the lung cancer management has undergone a recent changes. The entire paradigm of management has changed, particularly as we have moved away from the morphology towards the IHC, and now we are talking about the mutation-driven treatment of metastatic lung cancer. Also, in the early stages lung cancer, with the advent of driver mutation study, we know that the adjuvant treatment has also improved a lot, and a lot needs to be done. That is why it is very, very important for us medical oncologists to be apprised about all the latest happenings happening in this area. So keeping that thing in mind, so we have now joined together to discuss the management of lung cancer, the focus, but in general, what are the updates going on in this area in 2024? Without wasting much time, so I would just like to brief how the today's seminar is going to present. So first, we will have Dr. Aman Chaudhary. He will deliver a talk on the topic, and he's a consultant medical oncology in Bharati Vidyapeeth, Pune. Second talk will be taken by me. Then we have Dr. Nitin SG, who is a consultant medical oncology in CK Birla Hospital, Delhi. And in the last, we'll have a half-an-hour session by Dr. Shalabh Arora, who is a consultant medical oncology in Ujala Cygnus Hospital, Haldwani. So now for the first talk, I would like to invite Dr. Aman Chaudhary. Dr. Aman Chaudhary, please start with the presentation.
Yeah. Hi, Dr. Kapil. Thanks a lot for having me on this program. Just let me share my slides. Yeah, so is my screen visible?
Yes,
Sir.
visible.
Sure. Are slides moving?
Yeah, they are moving.
Yes, sir.
You can go ahead.
So today I'll be delivering a talk on molecular biomarker testing in lung cancer. So I'll be discussing under following heads. Firstly, I'll be discussing about the lung cancer incidence in India, biomarker testing in non-small cell lung cancer, evaluation of biomarker testing in non-small cell lung cancer, past and current, and what are the key takeaways. So the burden of lung cancer in India, as per the Globocant 2020, we can see here that if we include both the sexes, the lung cancer accounted for the fourth most common cancer in whole of the population in India, and it accounted for close to 5.5% of the cases. And if we see in the males, it accounted for 8% of the total cases and was the second most common cancer in the males. So this table again shows that lung cancer was the fourth most common cause of death caused by the cancer. So there are 50% of patients with advanced non-squamous cell carcinoma. Just a minute, give me a minute. So the 50% of patients with advanced non-squamous non-small cell lung cancer have a driver mutation which is targetable, and we have many such FDA-approved agents which can target that mutation. For example, AL can be targeted by crizotinib, alectinib, ceritinib, lorlatinib, brigatinib. For EGFR, we have gefitinib, erlotinib, afatinib, osimertinib, dacomitinib. For KRAS, we have sotorasib, adagrasib. For exon 20 insertion mutation, we do have amivantamab. For MET exon 14 skipping mutation, we have capmatinib and tepotinib. For HER2, we have TDXD and also TDM1. For ROS, we have we have crizotinib and entrectinib. For BRAF, we have dabrafenib plus minus permatinib. For RET, we have salpercatinib plus prazeltinib, and for NTRK, we have entrectinib and dabrafenib. So the importance of biomarker testing in lung cancer lies in the fact that studies have shown that patients with identified actionable mutation who receive appropriate target therapy have improved outcomes. As is seen by this Kaplan-Meier curves, we can see that the patient who received target therapy had a median OS of close to 19 months, and those who didn't receive any targeted therapy and received only conventional chemotherapy had a survival of only 11.5 months. So the guidelines recommend to test for the following biomarkers, which include EGFR, ALK, ROS1, BRAF, MET exon 14 skipping, RET gene, NTRK, KRAS, and PD-L1. Although guidelines differ in their preferences of testing, but NCCN says that we should test for all of these biomarkers, and we do follow the NCCN guidelines. So there are various methods of testing, these biomarkers in non-small cell lung cancer tumor samples. We can either use DNA sequencing, NGS or PCR. We may also use RNA sequencing, which detects fusion abnormalities. It is more sensitive for ALK, ROS1, RET, and NTRK. We may also use IHC or FISH-based testing. FISH is usually used for ALK or ROS1, and it can be, pretty faster. And IHC is also used for ALK and ROS1. It is a easily available test, and we usually do testing for ALK by IHC, and for ROS1 we do screening by IHC, and if it turns out to be positive, then we confirm it by FISH. So the journey of the biopsy to analysis, the preliminary diagnosis of lung cancer is made by biopsy, and the tissue can be allow me a minute. There's a pitch. So the tissue can be either obtained by resection, excision, or a small biopsy, and they are then converted to FFPE block. Fine needle aspiration cytology or exfoliated cytology can also be used if doing a biopsy is not feasible. And if there is no accessible lesion, then we may also go for blood-based liquid biopsies. So histology and cytology is then followed by DNA analysis or RNA analysis by PCR, for various cancer gene panels, for MSI, for whole exome sequencing, whole genome sequencing, or we may also do targeted mutation testing. RNA testing, RNA is also tested for certain gene expression panels. We usually use RNA-based testing for the MET exon skipping 14 mutation, which I'll be discussing later on. The biopsy is done to establish diagnosis and to determine the histologic subtype, and also for the biomarker testing. So the first thing is to differentiate between the squamous and non-squamous. And for the biomarker testing, primary tumors and the metastatic lesions have equally suitable. So we may use any one of them, which is easily accessible. So bone biopsy can be suboptimal due to decalcification, which leads to degradation of DNA. Liquid biopsy, which tests the cell-free DNA in plasma, are the other options in which in patients who are very, very morbid, who are elderly, and who may not be able to undergo invasive processes like biopsy. So tests for EGFR, ALK, ROS1, BRAF, V600E, NTRK, RET, and MET exon 14 in on non-squamous NSCLC is recommended. We usually recommend a broad NGS testing to detect most mutation using least amount of tissue. But if it's not feasible to use a broader NGS, then we may select these 12 genes which we have highlighted previously. For squamous NSCLC, consider testing in young, never or light smokers, or if biopsy specimen is of mixed histology. So testing for PD-L1 expression is also done in all the non-small cell lung cancer patients. So completion of testing within 10 to 14 working days of biopsy is recommended. Circulating tumor DNA testing has the potential to be applied across all stages of non-small cell lung cancer and throughout the treatment pathway. It may be used for diagnosis and treatment selection. It can also be used for monitoring prognosis, response to treatment, and progression or relapse of disease. Although we don't know the implication of this, whether it will early detection of ctDNA in a patient will improve survival or not, but still we may use it. ctDNA testing overcomes some major challenges associated with tissue testing, which includes it is a minimally invasive for patients, allowing for serial biopsy if needed. ctDNA in the bloodstream is comprised of DNA from all tumor sources in the body and captures both tumor heterogeneity and tumor changes over the time. So the ctDNA testing may never replace tissue biopsy entirely, but could have a complementary role to support treatment selection in patients with the NSCLC. ctDNA may be used to detect MRD after surgery in resectable NSCLC. As I have already told, we do not know the implication of this, and we need additional studies and long-term follow-up to find out if there is any benefit of detecting ctDNA post-surgery. So there was this study, TRACERx study, which included 24 early-stage non-small cell lung cancer patients, which were followed longitudinally after section, and they were tested for the ctDNA. 93% of the patients with disease recurrence were MRD positive, and 90% of the those without recurrence were MRD negative. So in the TRACERx study, ctDNA profiling was able to confirm MRD negativity and detect MRD in patients who were relapsed before the disease was picked by standard imaging. So this table shows the comparison of tissue versus liquid biopsy testing. For tissue, we have to go for an invasive procedure, but liquid biopsy is simple procedure. We have to just draw our blood. Repeat sampling is very, very feasible in liquid biopsy because it is a minimally invasive technique. And for in case of tumor tissue, there can be a correlation with biopsy and the cellular phenotype possible. But this is not feasible in the liquid biopsy specimen. The sensitivity of tissue-based testing is in lower tumor cell content is acceptable, and it is very sensitive method with liquid biopsy is a very sensitive method as ctDNA may comprise less than 0.1% of the cell-free DNA. So multiple genes are involved in non-small cell lung cancer pathogenesis. Single gene reflex testing or multiple gene testing by NGS may be employed as highlighted in this simple algorithm. So what are the advantages of NGS? So NGS has a number of advantages over single gene test. As the number of clinically actionable biomarkers has increased, the ability to evaluate all molecular alteration in a single test has given NGS a major advantage. So if one or few molecular markers are needed, higher cost in longer turnaround time versus single gene. If many molecular markers are needed, reduced cost, shorter turnaround time, and lower tissue requirement versus a single gene. So pros of using NGS is that it detects a broad range of molecular alteration, may identify new markers that could offer additional treatment options for a patient and provide information to help the development of new and more effective treatments. Cons of NGS are that it is highly complex test. It involves trained personnel to evaluate or assess the results. So techniques and molecular landscape in non-small cell lung cancer, we do have various techniques. We can either use a single gene assay, we may use Sanger sequencing, pyrosequencing, allele-specific PCR, single base extension. We may use MLPA, which is usually used for detecting larger deletion and duplication. We may use gene panel assays, we may use NGS. So for EGFR, we may use PCR, we may use Sanger, we may use NGS, or but I don't think so IHC. For KRAS, we use either PCR or DNA sequencing. For MET, we go for NGS or real-time PCR. For ALK, we go for ALK FISH and ALK IHC. If still in doubt, we may go for the FISH as well. For BRAF, we use PCR, NGS, ROS1, IHC, or FISH, or NGS, RED, PCR, FISH, and so on. So EGFR mutation in lung adenocarcinoma, sample types which can be used are fresh frozen paraffin-embedded sections. We may use cytology specimens, or also suitable, like cell blocks. So discordance between EGFR mutation status in primary tuber and corresponding metastatic sites are rare. So we may employ any of the site for the testing of the biomarker. So EGFR testing, what is the role in the early lung cancer? NCCN recommends EGFR testing in early stage non-small cell lung cancer, as is seen in the following table. We see that NCCN says consider adding molecular testing for EGFR mutation to be performed on diagnostic biopsy or post-surgical resection sample to ensure EGFR mutation results are available for adjuvant treatment decisions for patient with stage 1B to 3A NSCLC. So what is the advantage of NGS over PCR? One study showed that 48.6% of EGFR exon 20 insertion mutations identified by NGS are missed by PCR. So out of the 17 most common EGFR exon 20 insertion mutation variant, only 4 can be identified PCR. So this is the edge of NGS over PCR. Now few words about the ALK rearrangement in SCLC. So there's a pretty good correlation between the ALK-IHC and ALK-FISH, as is shown in multiple studies, which is highlighted in this table. So false positivity rate of 0.1% can be seen with FISH, but IHC on the other hand is less expensive, hence more widely adopted. Few words about the ROS1 rearrangement in non-small cell lung cancer. For any non-small cell lung cancer patient, we do test for EGFR, ROS1 and ALK. ROS, we initially screen by IHC. If IHC is positive, we do have to reconfirm via doing other method like a FISH or a NGS. So KRAS mutations are mutually exclusive with EGFR and ALK mutation and account for nearly 30% of the lung adenocarcinoma. The most common of these arise in the codon 12 and 13, with the G12C variant found in 13% of patients with lung adenocarcinoma, and it's predicting poor prognosis versus wild-type KRAS. So it can be detected by a multi-gene NGS panel. We do have targeted therapies available for KRAS. We have sotorasib and we have adagrasib for that. So BRAF mutation are seen in more than 50. BRAF V600E is shown in more than 50% of patients who have BRAF mutation, and is thought to be more prevalent in smokers, which is in stark difference to the other mutations which are usually seen in non-smokers. So non-V600E mutations such as V600K, G466V, G469A are less prevalent and occur in close to 17% of patients with BRAF. Overall, 1 to 5% of the patient with NSCLC harbor BRAF mutation. The method of testing is via PCR or via NGS. We do have target therapy, which include dabrafenib plus tremelimumab against BRAF V600E mutation. So MET is MET exon 14 skipping mutation is found in 3 to 4% of non-small cell lung cancer and 20 to 30% of sarcomatoid cancers. So majority of MET exon 14 skipping mutation can be detected by DNA NGS, but increased sensitivity with use of RNA NGS. So here lies the role of using RNA for the biomarker testing. So IHC is not recommended for MET exon 14 detection. FISH is also not recommended. We may use PCR. And the most sensitive is the RNA NGS. So RET, on the other hand, is found in close to 1 to 2% of non-small cell lung cancer and 20 to 30% of the papillary thyroid carcinoma. Majority of RET fusion can be detected by DNGS, but increased sensitivity is found with use of RNA NGS. So with the various methods of RET fusion detection, we have IHC, FISH or DNA NGS testing, or as previously discussed, RNA NGS is the most sensitive test for detecting RET fusions. So how to test for NTRK fusions? For NTRK, we do have options of IHC, RNA or DNA NGS. We may use FISH or RT-PCR as well. So RNA NGS being the most sensitive, but IHC is the widely available and fast turnaround time. We also tend to confirm via FISH once we have found NTRK on IHC. So the choice of assay will depend on the institution, resource, and clinical context. Reflexing to NGS versus IHC is reasonable for NSCLC due to low prevalence of NTRK fusion. And important to qualify negative results is that there is a limitation of sampling or testing. So ESMO working group recommends that NTRK testing if desired. If is the tumor histologic type known to harbor highly recurrent NTRK fusion? If yes, then we go for FISH, RT-PCR or NGS. If no, then we may use IHC as a screening tool. If detection of TRK is found, then we may go ahead with the more confirmatory testing like NGS. So IHC advantage is that it is rapid, it detects transcribed and translated events only. It's a low cost test. It is widely available. Disadvantages include it may lead to depletion of tissue, fusion pattern and position is unknown and is less validated currently. FISH is rapid. Cons include again it may deplete tissue. In break apart FISH, we don't know the fusion partner and can be difficult to detect at times. NGS has potential for multiplex testing. It is less dependent on it carries lesser risk of tissue depletion because we need very less sample for detection. But the con is that it is a longer waiting time and cost definitely is an issue. The choice of assay will depend on institution, resource, and clinical context. We have discussed it previously as well. HER2 mutation in non-small cell lung cancer is seen in close to 3 to 5% of patients. It is mostly exon 20 in-frame insertions. It is mutually exclusive with other mutations and is seen mostly in never smokers. It carries worse ways than other subtypes of lung cancer mutation. In non-small cell lung cancer, HER2 mutation and amplification must be identified using a DNA NGS panel. IHC used to assess HER2 overexpression is seen in 59% of the cases, but it is definitely different from the HER2 mutation. So the treatment paradigm for NSCLC advanced is that if the patient has EGFR exon 19 or exon 21 mutation, we may use first or second or third generation of TKI. For exon 20 insertion, we may use amivantamab. For uncommon mutation, we may prefer afatinib or osimertinib. For ALK, we have various options like alectinib, lorlatinib, brigatinib, ceritinib. For ROS1, we have crizo or Entrek. For BRAF, we have tremi. For NTRK, we have entrectinib and darotriptanib. For RET, sulfatinib and prazitinib. I think I have discussed this in my initial slides as well. So PDL overexpression in non-small cell lung cancer. So we do have multiple platforms for detecting PDL1 expression. The most common is the DACO22C3, which is used, which is a companion diagnostic test for pembrolizumab. And for Durva, we have Ventana SP263. For Etizoli, we have SP142. For Nivolumab, we have DACO288. So again, this figure shows how slides look after specific IHC marking. A different scoring system is adopted depending on the antibody used to detect PDL1. So PDL1 is sole current biomarker able to guide immunotherapy. PDL1 negative tumors can still respond, albeit mostly when added to chemotherapy. And tumor mutation burden former marker for response, it is not currently used. MSI high or MMR not used or relevant in lung cancer, and LAC3 possibly related to resistance to immunotherapy is being studied. So to conclude, biomarker testing in non-small cell lung cancer has evolved from single gene to multiplex testing. Multidisciplinary meetings help in better understanding of sample and test requirements. Samples should contain adequate tumor content, at least 10%, to prevent delay in processing. An ideal TAT is 2 weeks, that is 10 working days. High throughput platforms such as NGS can be used to screen several genes at a time to provide results within the estimated time. So oncogenic targets and testing methodologies include the following. Clinical guidelines strongly recommend broader molecular profiling to identify rare driver mutations for which effective drug may be available or to appropriately counsel patients about available clinical trials. A broad molecular profiling is a key component of the improvement of care of patients with metastatic non-small cell lung cancer. Thanks a lot for patient hearing.
Thank you so much, Dr. Aman, for this wonderful presentation. I'm sure all of us learned a lot about the molecular biomarker testing in CA lung because this is an evolving area and it will be learning rare mutations and also how in presence of 2 or 3 multiple mutations, how one can affect the prognosis as well as the treatment implication of the same. So I just wanted to understand from your perspective that whenever suppose a new patient comes to you in OPD, and you have diagnosed that it's a metastatic NSCLC. So what are you currently opting for? The one is like hotspot testing versus the complete genomic profiling, that kind of testing, liquid biopsy versus tissue biopsy. So how is your approach going to be? Suppose the initial biopsy that patient is carrying is not sufficient. So you are content with the liquid biopsy, or you want to go for a repeat biopsy to send this in?
See, Kapil, if the pay, I do prefer a biopsy specimen because we have a biopsy specimen, we may also go for PD-L1 testing if we want in future. Liquid biopsy
Absolutely.
cannot provide you the PD-L1. If suppose if the patient turns out to be biomarker negative, you will have to go for PD-L1 testing as well. So definitely tissue has an upper hand. So I tend to go for tissue biopsies because in that, if the patient doesn't have histologic confirmation, why you will want to test? If it is small cell lung cancer, why will you test? So we also want to know if it is non-small cell lung cancer or not. So I
Absolutely.
think biopsy is mandatory, and I do prefer a broader panel provided if the patient can afford. If not, if the patient is very poor, I'll go for the basic three genes, the AL, CROS1 and EGFR.
Right. Absolutely, absolutely. And also, I wanted from you to understand, so when you're deciding for immunotherapy, so we know that the ALK and ROS mutations are a clear no zone.
Yes,
If there
exactly.
is a present that we don't go for immunotherapy. So
Yeah.
what about the MET, HER2 and NTRK, BRAF and so mutations? So are these also no-go zone, and like how's your
No, I don't
strategy?
think so. I think the data is there for ALK and EGFR if the patient is having carrying ALK or EGFR. I have read that they poorly respond to immunotherapy. I have not read about the other mutations, but definitely EGFR and ALK, they are poor responders to immunotherapy.
Absolutely. Okay, so if there are any other question in Dr. Aman, so feel free to ask. So I guess there are no further questions. So thank you so much, Dr. Aman, for joining us, and please stay online for the rest of the talks. So next,
Yes.
I will be taking the talk on adjuvant treatment of EGFR mutated NSCLC. So allow me to share the slides.
Hello, sir. Your video is not
Yeah,
proper.
I'm trying.
Just turn on your screen rotation on.
Just it's fine now. So actually, I am online through a tablet, and I'm having some difficulty in sharing my screen. So can
Sir,
somebody
should I
from the
share?
organization?
Yeah, I
Yeah.
will
Please,
share.
please share. Yeah. Yeah. Can you put it in the slideshow mode? Good evening, everyone. So I'm Dr. Kapil Goel. So topic assigned to me today is like reinventing adjuvant therapy in EGFR mutated early lung cancer. Next slide, please. So why is this topic important? So first we need to understand what is the survival of NSCLC after surgery. We know that survival outcomes in resectable NSCLC needs to be improved. In the lower diagram, you can see where they have shown global 5-year overall survival rate in patient with resectable NSCLC. When we talk about stage 1B, so it is only 65 to 75%, means approximately 25 to 35% patient will have a relapse. In stage 2, this number further goes down to 50 to 70% overall 5-year survival, and it is further goes down to 30 to 45% stage 3A. As most of the patients coming to us, even in resectable ones, are actually in stage 2 or stage 3. So over half of the patient will have a relapse or possible death. So that is why it is important that we need to strengthen our adjuvant strategy so that the recurrences can be prevented or at least delayed. We also know that lung cancer is the leading cause of cancer death, which accounts for almost 1.8 million deaths annually. It is one of the most common causes of cancer deaths. In India, lung cancer is approximately 75,000 cases per annum, and a high number of mortality are caused by this. NSCLC represents approximately 80% of all lung cancer diagnoses. Rest are small cell lung cancer, and estimated 30% of the patient present with resectable disease at diagnosis. So even though more than two-thirds of the patient have metastatic disease at presentation, but still a sizable chunk of the patient come in the resectable stage when we do for the resection. Also, because as we have more and more CT scan being done for other symptoms and for as of evaluation of other benign conditions, so the diagnosis, incidental diagnosis of NSCLC is also increasing. And in future, we know that the percentage of patients who come to us in stage 1, 2, and 3, that is resectable stage, will also go up. Next slide, please. So this topic has been dealt extensively by Dr. Aman Chaudhary previously. So what are the testing recommendation in early lung cancer? So these are the expert consensus recommendation on biomarker testing in metastatic and non-metastatic NSCLC in Asia. The Indian representation is by Dr. Ullas Batra, who is in Rajiv Gandhi Cancer Institute. So in non-metastatic resectable lung cancer, first of all, we need to minimally test for EGFR and PD-L1. Also, we are also now, after the ALINA trial, we have also started testing for ALK sample also. If the patient has EGFR mutation positivity, like exon 19 deletion or L858R mutation, or patient can have EGFR mutation negative, PD-L1 positive, or patient can have both EGFR mutation and PD-L1 negativity. According to that, we have to follow the appropriate treatment recommendation, which can comprise of the neoadjuvant component immunotherapy there, or adjuvant component in which the EGFR inhibitors are given in adjuvant setting. Next slide, please. Next slide, please. So what is the current testing and treatment pattern? So this is presented in ASCO 2023, where they showed that the prevalence of EGFR mutation in patients with resected stage 1 to 3 non-squamous NSCLC in the early EGFR study, they have shown. So overall, if you look, so EGFR mutation is present in approximately 51% of the 50% of the patients. But if you look at the exon wise, so 50.5% of those have 19 deletion. Rest 36.0% are L858R mutation. 3.3% had de novo T790M mutation. Some other rare mutation or compound mutations were also seen. This study enrolled consecutive patients with surgically resectable pathological stage 1A to 3B non-squamous NSCLC between March 21 and October 22 at 33 centers across Middle East and Africa, Latin America, and Asia. EGFR mutation prevalence of 51% with deletion 19, the most common, followed by L858R. So that is how you can see that almost half of the patient have EGFR mutation positivity, which is much higher than what is quoted worldwide. Next slide, please. Also, they've seen the prevalence of EGFR mutation in the same study, how the along with the different stages, how does it carry out? If we look at the overall, so 73.2% patient underwent surgical resection only, while 22% patient received some kind of systemic therapy along. If you look at the stage 1A and 1B, in 1A, almost all of the patients receive surgical resection only, with very few patients receiving systemic therapy, obviously, because stage 1A. In stage 1B, the number of patients who receives systemic therapy also increased to 22.5%. In stage 2A, it increased to 38.2%. In stage 2B, number of patients who received systemic therapy increased to 33.7%. From this stage onwards, patients start receiving some kind of adjuvant radiation therapy. Also, 7.4% patients received adjuvant radiation. If we look at the stage 3A data, 12.1% patient received surgical resection along with radiation therapy and systemic therapy. Half of the patient received systemic therapy. So this is the first time where actually the number of patients who receive systemic therapy exceeded those of who undergoing surgical resection alone. 33.3% patient receive surgical resection alone. If we talk about stage 3B, here majority of the patient, that is 42.9% patient received surgical resection with adjuvant chemotherapy. while equal number of patient, 28.6% patient received surgical resection alone and surgical resection plus RT plus ST. So to comprise all of them, more than 2/3 of these patients underwent only surgical resection. And if we talk in patient with stage 2 and 3 NSCLC, only 46.3% patient received adjuvant systemic therapy. The reason behind most of the patient not receiving any adjuvant systemic therapy, performance status and financial reasons. Next slide, please. Next slide, please. So after initial treatment, more than half of the patient with resectable NSCLC experience recurrence within 5 years, as I have already discussed in the previous slides. After the patient undergoes surgery, 50 to 60% of these patients recur, while only 40 to 50% patients remain cancer-free after long follow-up. In these recurrences, they can be either the local recurrence at the time of surgery or they can have distant recurrences. Now, given that over half of the patient recur after curative intent surgery, there is an unmet need for improved neoadjuvant as well as adjuvant treatment options in order to improve outcomes. Next slide, please. This is the ANITA studies, which studied adjuvant chemotherapy after surgery for stage 1B to 3A NSCLC. And it showed that adjuvant chemotherapy in this stage improved OS and DFS by 5% after 5 years. On the left side, we have the OS Kaplan-Meier survival curve, where the pink line is represented by the arm which received chemotherapy, and the dark purple line is the observation arm. If you look, the curves are separating nicely, and which is statistically significant. On the right panel, we have DFS curve, where the pink line is chemotherapy and the dark purple line is observation. And here also the delta of benefit is also large. Next slide, please. So what is the status of using EGFR tyrosine kinase inhibitor in the adjuvant EGFR mutated NSCLC setting? So various trials have been conducted in the past using various first generation and second generation EGFR TKIs. However, none of the trial translated into approval or change in clinical practice in adjuvant setting, because many of the trial, although did show some DFS advantage, but none of the trial showed any kind of OS advantage. The major trial in this was SELECT trial, which were done in USA, which took stage 1 to 3A EGFR mutated NSCLCs. Here, erlotinib was given after adjuvant chemotherapy plus minus RT. It included 100 patients. 2-year DFS of 88% versus 76% historical control, because a randomized arm was not there. So that is why the result of this trial cannot be interpreted into clinical practice. Second trial was RADIANT trial, which was done globally across multi-center. Stage 1B to 3A EGFR expression or amplification patients were taken. Total 973 patients were taken. They were divided into two arms, one receiving erlotinib and the control arm receiving placebo after adjuvant chemotherapy. So clinically meaningful DFS improvement was seen in EGFR mutated subgroup, that is 46.4 months versus 28.5 months, although no OS benefit was seen in this trial either. Next, we have EVAN trial, which was done in the Oriental country, Taiwan and China. The stage 3A EGFR mutated patients were taken. So we have to take care that in this trial, very highly selective population of stage 3A was taken. Here they were 102 patients were randomized into two arms. One was erlotinib, that was experimental arm, and the control arm was adjuvant chemotherapy. It also showed significant DFS improvement of 42.4 months versus 21 months, which is also statistically significant. However, this trial also failed to show any OS advantage. Next, we have adjuvant CTONG 1104 trial, which is also a China trial. Stage 2 to 3A N1 to N2 EGFR mutated lung cancers were taken. They were randomized into two arms. One received geftinib versus adjuvant chemotherapy. The sample size were 222. They showed significant DFS improvement of 28.7 months in the geftinib arm compared to only 18 months in the adjuvant chemotherapy arm. However, there was no significant OS improvement, with the OS remaining 75.5 months versus 62.8 months. So numerically, the OS was also higher, but if we put it through the statistical analysis, the hazard ratio was 0.92, which was reaching the limit of confidence interval, and it was not statistically significant. Next, we have the BR.19 trial, which is a Canadian US trial, in which the stage 1B to 3A EGFR unselected patients were taken. They were randomized into two arms, geftinib versus placebo.
Sir, you are mute.
Hello. Yeah, next slide, please. Next slide, please. So the question arises that why these data have not resulted in a change into clinical practice. So basically, because trial till date have been limited by the design, size, and other factors, and there no OS benefit has been demonstrated in either of the trials. It is unclear whether adjuvant EGFR TKI therapy results in the cure of the disease or whether it is just preventing the recurrences. Also, there is no definite evidence on appropriate sequence, drug, or duration of the treatment. Next slide, please. Now we will then talk about the ADAURA trial. So ADAURA was the adjuvant osimertinib trial that was done. So in this, the patient with completely resected stage 1B, 2, 3A, NSC, LC were taken who have or have not received previous chemotherapy. Key inclusion criteria were more than 18 years of age. In Japan and Taiwan, 20 years age group was taken. And WHO performance status has to be 0 or 1. And brain imaging was required if it was not done preoperatively. Also, the maximum interval between surgery and randomization. If the confirmed primary non-squamous NSC LC exon 19 deletion and L858R mutation were taken. So these patients were stratified by the stage 1B versus 2 versus 3A, EGFR mutation type like exon 19 deletion versus L858R, and race the Asian versus non-Asians. These were randomized into two arms in 1:1 ratio. The experimental arm received osimertinib 80 mg once a day, while the control arm received only the placebo once daily. The primary planned treatment duration was 3 years. The treatment was continued until disease recurrence, treatment completion, or discontinuation criterion were met. Follow-up was done according to the schedule until recurrence, week 12 and 24, then every 24 weeks to 5 years, and then yearly. After recurrence, every 24 weeks for 5 years, then yearly. The endpoints. Primary endpoint was DFS by investigator assessment in stage 2 to 3A patients, and key secondary endpoints were DFS in the overall population, stage 1B to 3A, landmark DFS rates, overall survival, safety, and health-related quality of life. Next slide, please. So these are the efficacy data of ADAURA trial. It was shown that ADAURA trial significantly improved DFS in primary as well as overall population. So on the right side, we have Kaplan-Meier curve of overall population, where the blue line of osimertinib and yellow line of placebo are separated nicely, and they start separating from the beginning itself. Here, the median DFS was 65.8 months in the osimertinib arm versus 28.1 months in the placebo arm, with a hazard ratio of 0.27. So it is really miraculous and marvelous that the hazard ratio of that extent is reached in the adjuvant setting. It is almost unheard of. Maturity at this time is 45% in the respective arms. Particularly if we focus on stage 2 to 3A arm, 3A stage. So median DFS here was in the osimertinib 65.8 months compared to 21.9 months in the placebo, with a hazard ratio of 0.23. So this kind of benefit in the adjuvant setting is previously unheard of, particularly in the lung cancer. So that is why it shows how important these findings are. Next slide, please. The benefit was not restricted to only overall DFS, but the CNS DFS was also significantly improved with adjuvant osimertinib. As we know that the CNS metastases are a poor prognostic factor among patients with NSCLC, and these are associated with deterioration in quality of life. Improved CNS efficacy with osimertinib treatment was seen, and osimertinib has been shown to have greater penetration of blood-brain barrier and higher exposure in the brain compared with other EGFR TKIs. Adjuvant osimertinib demonstrated CNS DFS benefit versus placebo in both the stage 2 to 3A and 1B to 3A populations. In the right side, the Kaplan-Meier CNS DFS analysis is shown, which were published in JCO in January 23. Here, the median CNS DFS was not reached in either of the arm. However, we can clearly see that the curves are separating nicely, and hazard ratio is also 0.24, which is marvelous, and it clearly indicates the superiority of osimertinib in the CNS activity also. Next slide, please. If we look at the safety analysis, the no news adverse signals were noted when compared to primary readout of ADAURA data. Any adverse event of any cause were there in more than 90% of the patient in either arm. However, if we look at the grade 3 or more reactions, they were present in 23% of the patient. One patient died because of the adverse event, and the adverse event of serious nature happened in 20% of the patient. However, the treatment discontinuation or interruption was required in 13% of the patient. AE causally related was there in 91% of the patient. However, only 11% of the patient had grade 3 or more reaction. There was no death. At the time of current data cutoff for OS, one additional serious adverse event had been reported, which occurred more than 28 days after treatment discontinuation. And it has been determined by the investigator that this was not treatment related and the patient made a full recovery. Next slide, please. So the key takeaway points are, in order to improve survival, we need to put more efforts to identify lung cancer early. So as we have seen that from stage 1B, 2 to 3, the survival also deteriorates. So that is why as much as the number of patients we can identify in the early stage, the survival will be better. Never miss an opportunity to test for actionable mutation. Still, many of the patients do not undergo driver mutation testing because of various reasons like availability and financial. But as far as possible, we should try to get testing for actionable mutation, the bare minimum being the EGFR, ALK, and PDL1. And this applies in early lung cancer as well, especially for EGFR. Collaboration with multidisciplinary team is key, which include the surgical oncologist, cardiologist, pulmonary rehabilitation, pulmonologist, nursing staff, psychological, and medical oncologist to improve survival. Next slide, please. Patient may ask for treatment options for best survival probability, and that is why the medical oncologist should always be ready to give options and be ready to discuss and offer them as per the best available data. Not just data, we also have to know the pros and cons of each options, and that can empower patient to take the decision that is best for them. ADAURA data gives a probability of patients to remain cancer-free along with survival benefit, as we have shown in the previous slides. Being cancer-free is goal of patient as well as his or her treating physicians. Next slide. Thank you so much for the patient listening. If there are any questions, I'll be happy to answer. So since there are no questions, so I think we can move ahead in our program. So now I would like to invite Dr. Nitin SG, who is a consultant medical oncology in CK Birla Hospital, Punjabi Bagh. Dr. Nitin will be talking about optimizing treatment in advanced EGFR mutated lung cancer. Over to you, Dr. Nitin.
Good evening, all. Thank you, Dr. Kapil and the organizers for inviting me for the session. So, my topic is, am I audible?
Yes, Dr. Nitin, you're audible.
And
On
slides
slide.
are moving, right?
Yes, they're moving.
Okay, so the topic is optimizing treatment in advanced EGFR mutated lung cancers. So, Dr. Aman and Dr. Kapil have extensively discussed the role of mutation testing and significance of newer generation EGFR TKIs in the treatment of lung cancer. So there are multiple various targets available nowadays in lung, and targeted therapies also available readily. So all lung cancer patient newly diagnosed should undergo the mutation testing for identifying the specific target. And the role of osimertinib in adjuvant setting has been very well explained by Dr. Kapil. So I'll be discussing EGFR mutation positive non-small cell lung carcinoma, the role of EGFR TKIs in advanced setting. So as we discussed earlier, EGFR mutations are observed in around 40% and 20% of patients with NSCLC in Asian and non-Asian population respectively. The incidence rate of EGFR mutation in the Indian population is around 20 to 25%. EGFR mutations are, as we described earlier, EGFR mutations are located in the tyrosine kinase domain and result in increased kinase activity of the EGFR, leading to continued cell proliferation. So the most common EGFR mutation which is targetable and which is in general seen amongst our population is exon 19 deletion and exon 21 L858R point mutation. There are other mutations, various other mutations, especially exon 20, which also have got targeted agents getting approved in the treatment in upfront setting for in EGFR mutated exon 20 insertion setting as well. So based on the EGFR mutation status, we have got mainly 3 generations of EGFR TKIs, which have totally changed the treatment armamentarium of EGFR mutated lung cancers, and the survival of these cancers, especially the metastatic stage 4 or metastatic disease, their survival has improved from months to years with the introduction of these drugs into the treatment list of patients with metastatic non-small cell lung cancers. Mainly, there are 3 generations. First generation include erlotinib and geftinib. Second generation afatinib, dacomatinib, and the major game changer in the treatment of lung cancer is osimertinib, which is a 3rd generation TKI. First generations are usually act by they usually bind to the EGFR tyrosine kinase in an reversible manner, usually bind to wild type as well as mutant EGFR, and hence in general their side effects are also more non-specific, and they are not active against T790M mutant lung cancers, which is the most common secondary resistance seen with EGFR TKIs. Afatinib and dacomatinib also belong to the ERBB family. They also block the ERBB family of receptors. They act on both EGFR as well as ERBB2 and ERBB4, and they usually bind through a covalent binding, leading to irreversible inhibition of these receptors. And hence, they have got a broader activity as compared to first generation TKI. Afatinib is even approved for rare mutations associated with rare mutations in EGFR as well, other than exon 19, exon 20. 21 changes. And 3rd generation include osimertinib, which is actually EGFR mutant specific inhibitor. It also binds irreversibly to the EGFR tyrosine kinase receptor and thus specifically inhibit EGFR in an irreversible manner. And they also have high specificity for EGFR T790M mutant variant, thus leading to it is very effective in cases where there are T790M mutation. And initially, it has been considered to be an effective drug after a patient develops secondary resistance in the first line setting after giving a first generation TKI. But now they have came up all the way to the first line of treatment in metastatic non-small cell lung cancer. So osimertinib is the new standard of care for first-line therapy in patients with EGFR mutated advanced non-small cell lung cancer. The FLORA trial was the first trial that actually brought about EGFR TKI into the treatment armamentarium of, osimertinib into the treatment armamentarium of lung cancer. Even though other first generation, second generation TKIs have been approved, but the game changer was osimertinib through FLORA trial. So FLORA trial was a randomized double-blind phase 3 study to assess the safety and efficacy of osimertinib versus standard of care EGFR TKI as first-line treatment in patients with locally advanced or metastatic EGFR mutated non-small cell lung carcinoma. Osimertinib is structurally distinct from first and second generation EGFR TKIs. As we discussed earlier, they are structurally different. They are different. Their prodrug is also quite different. For example, geftinib, erlotinib are mainly quinazoline variant, while osimertinib is mainly monoanilinopyrimidine. So structurally, they themselves is different. Their sensitivity towards EGFR is different. Their binding pattern is different. EGFR osimertinib is irreversible binder. It's highly sensitive to EGFR, and they are also sensitive to T790M's mutation. They covalently bind to the receptor and thus irreversibly inhibit the receptor, thus leading to their marked response. Osimertinib is the 3rd generation irreversible CNS active EGFR TKI developed to selectively target both EGFR sensitizing and EGFR resistance mutation, especially T790M mutation. So another important advantage of using osimertinib is their high CNS penetration. Rest of the EGFR TKIs, because of their structural variation, they are not that penetrant into the CNS, while osimertinib has got a very good penetration across the blood-brain barrier, thus having a very high concentration in CSF, preventing metastatic progression in brain as well as it is also effective if already brain mets are present. So FLORA study design, patients with locally advanced or metastatic non-small cell lung carcinoma more than or equal to 18 years of age with WHO performance status 0 or 1, having an exon 19 deletion or L858R, with those who have never received any prior anti-cancer therapy or EGFR TKI with stable CNS mets were included in the study. They were substratified on the basis of the mutation status as well as on the basis of race, whether Asian or non-Asian. So the patients received osimertinib. The treatment arm received osimertinib 80 mg once daily, and the comparator arm received EGFR TKI, mostly first generation TKIs, geftinib 250 mg once daily or erlotinib 150 mg once daily. And they all were assessed after 6. They were randomized 1:1, and they were reassessed using imaging at 6 weeks for objective evidence of any progressive disease or response. So primary endpoint was progression-free survival based on investigator assessment according to RECIST 1.1. And secondary endpoints include objective response rate, duration of response, disease control rate, depth of response, overall survival, patient-reported outcome, and safety. Crossover was allowed in the comparator arm. Those patients who receive first generation TKI, if they have progressed at the 6 weeks evaluation, they could be they have been put on the third generation TKI. This crossover was allowed in FLORA study design. So these are the PFS results of FLORA trial, where we can right from the Kaplan-Meier curve, we can see that both the curves are beautifully getting separated, showing a marked improvement in progression-free survival of patients who are receiving osimertinib. Median progression-free survival was 18.9 months as compared to 10.2 months in those who were receiving first-generation EGFR TKI. Hazard ratio was 0.46, which was statistically significant with a p-value of less than 0.0001. PFS is a direct measure of the drug's benefit, and FLORA was powered only for PFS. This is the forest plot showing the subgroup analysis of those patients who have been included in the study arm, and we can see that there was no difference, and all the subgroups, whether it be based on the age, sex, race, smoking history, CNS metastasis, and everything, all the patients have shown benefit with osimertinib as compared to first generation EGFR TKIs. The overall survival result, final analysis have also shown benefit. The median overall survival was more than 3 years in patients receiving osimertinib, which was quite strikingly different from that of first generation EGFR TKIs. The median overall survival was 38.6 months as compared to first generation EGFR TKI, which was 31.8 months with a hazard ratio of 0.799. Which was statistically significant. Osimertinib patients were more likely to be alive at 2 and 3 years landmark, as we can see in the Kaplan-Meier curve. At 2 years and 3 years, more percentage of patients, at least 20%, there was difference of at least 15 to 10 to 15% difference between both the comparator arm at each time interval. First time an EGFR TKI has translated PFS to a significant overall survival benefit. 28% of the patients were still receiving osimertinib at 3 years. 9% of patients in the first generation TKI arm were receiving therapy, while 28% of patients in the osimertinib arm were still on osimertinib without any progression and showing a marked improvement in their disease response. 28% of patients were still receiving osimertinib at 3 years, which was 3 times more than patients in the comparator arm. 22% versus 5% of patients still on treatment at data cutoff. Time to first subsequent therapy, we can see that time to first subsequent therapy was also markedly prolonged in patients who were receiving osimertinib, with median duration for starting the second line of therapy was 25.5 months in patients receiving osimertinib, while it was 13.7 months in patients receiving first generation EGFR TKI, and the hazard ratio was 0.478, which was statistically significant. Efficacy of osimertinib across clinical subgroups in the PFS, as we discussed earlier, all subgroups have shown strikingly significant improvement in progression-free survival, whether it be based on the sex, race, CNS status, EGFR mutation status, or whether EGFR mutation has also been stratified on the basis of ctDNA levels, and all these subgroups has got benefit with osimertinib. In overall survival, the data was quite mixed. The study was not actually powered for subgroup analysis in the OS. Even OS was not the primary endpoint for the study, and the subgroup analysis was also not that significant. There was not much. There was significant only in those patients who had exon 19 deletion. Rest all had got response, especially in non-Asian population, and exon 19 deletion had a significance in overall survival, but this was not conclusive because it was not powered for the same. Osimertinib's PFS benefit was clearly maintained consistently across all subgroups, demonstrating its superior benefit across all population, including by race and across the different mutations types, which is important as we discuss OS subgroups. All OS subgroups showed a positive benefit in favor of osimertinib, although magnitude of benefit varies. This is consistent with PFS data in which all subgroups favored osimertinib. The synopsis of why do we think it is important that patients receive osimertinib in the first line. So currently, NCC and ESMA and all the guidelines say that osimertinib has to be given to the patient in the first line setting itself if EGFR mutation is present, especially osimertinib sensitive mutations are present, and unless otherwise, it has to be given to all patients. And what is the basic concept behind that? Approximately 30% of all patients are eligible for osimertinib as second line treatment for T790M mutation positive NSCLC following progression on a first line second generation EGFR TKI. So whenever we start the patient on a first generation EGFR TKI, it is found that 50% of patients who are alive and who are able to get an accurate test result will test for T790M mutation positivity. So all those patients who have progressed, of which only 50% of patients would be either alive or would be available to get an accurate test for T790M mutation. And of that 50% of patient, only 60 to 70% can receive an accurate T790M mutation result, and of which, because the rest of the patient may not be eligible for tissue biopsy, maybe insufficient tissue from biopsy or an invalid test result or a false negative on plasma test. Only 73 to so ultimately only 73 to 77% of EGFR mutated patients receive any second line therapy, either the rest of the patient either die during the first line therapy or receive only palliative care upon progression. So overall, it was found that only 30% of the patients are ultimately eligible for osimertinib in the second line setting, especially if they have received first line EGFR TKI and have progressed and developed T790M mutation. So this is a diagram depicting the same, in which we are seeing around 10 patients who have been started on first line EGFR. Around 73 to 77% of EGFR mutated patients will receive second line therapy, and rest of the patients, around 30% of the patients might die or may fall out of treatment and may go into a palliative setting, or may not be aware, or those patients may not have a disease which is amenable for biopsying or testing for T790M mutation testing. Of this 73 to 77%, around 60 to 77% can receive a testing for 790M mutation. Rest of the patient may not have a tissue biopsy or insufficient tissue, invalid test result and all. Of this 60 to 75% of patient, only 50% of the patient with a valid test result for T790M will be turning out to be positive for T790M. So overall, if we look into it, it would be of the 10 patients, only 3 patients will be eligible for second line osimertinib, which constitute around 30% of the total number of patients. So only 60 to 79% of patients can receive an accurate T790M test result. Not all patients are able to receive a valid T790M test result upon rebiopsy, and plasma testing may yield a false negative result as well. So these are few studies that actually compared the percentage of patients that studied about the percentage of patients who could go ahead for testing for resistant mutation, or who could rebiopsy, or who could go for second line therapy with an higher generation EGFR TKI. And most of these studies have shown that only around 60 to 70% of patients would be going for the rest of the therapy or second line of therapy. Crossover rate and subsequent second line therapy for the FLORA experimental arm. So this is a FLORA experimental arm. Of the 100% of patients who receive osimertinib, only 20%, 22% of patients at the time of analysis, only 22% of patients were continuing on treatment. 78% of patients had discontinued. Of the 31 of the patient who have discontinued, 31% of the patient in the experimental arm could not receive a second line therapy, or they could not receive any no subsequent therapy. On the other hand, 48% of patients received second line of therapy, which could be either, of which around 29% which were EGFR TK other than osimertinib, 3% received other therapy, and 68% of patients received cytotoxic chemotherapy. So of the whole population, 22% still continued on osimertinib, and around 48% were eligible for second line therapy. In the comparator arm, as we can see, only 5% of patients were continuing on EGFR first line TKIs at the time of data cutoff. And those patients who have discontinued, 95% of patients have discontinued therapy either due to progression or toxicity, of which only 30% of the patients were, and 30% of patients could not receive any second line therapy, and 65% of the patients received some form of second line therapy, of which 47% of patients receive osimertinib. So this represents around 31% of all patients. Of the 277 patients in the comparator arm, only 85% patients could receive second line osimertinib, which constitute around 31%. So these are few studies where first generation TKs have been used. The IPAS trial for Geftinib, or UOTAC trial for erlotinib, Ensure trial for erlotinib, and all these studies have shown that around 70, it constitute around 60 to 70% of patients were only 60 to 70% of patients could receive some form of therapy, and most likely a second line of therapy post first generation TKI in the first line setting. On the other hand, in Flora, 48% of patients who had osimertinib could go ahead with second line of therapy. So this is a real world data. In a real world study of patient with EGFR mutated non-small cell lung carcinoma, the risk of not receiving second line therapy was very high. So this was a retrospective study from a real world study. 140 patients with EGFR mutated non-small cell lung carcinoma in Germany was analyzed, and was found that 130 of 140 patients were treated with first line EGFR TKI, and 10 patients received first line chemotherapy, of which 112 patients were candidates for second line therapy, and 34 of these patients did not receive any second line therapy, of which 30% of patients didn't receive any therapy. And reason for not receiving second line therapy is either patient refusal, or poor progression, poor performance status, or fast progression and death. So 104 patients in this study were treated after accessibility to third generation TKI. So across all lines of therapy, only 29% were treated with a third generation TKI after accessibility. So these are multiple real world data across multiple countries, and all these confirm that in clinical practice, only one third or fewer patients will receive first, second line osimertinib, and that's the reason why osimertinib came up into the first line, where it is very effective, it improves survival, and all the patient would be eligible, and all the patient would be able to take osimertinib at the first line itself. So this is a head-to-head clinical. There were multiple head-to-head clinical trials of EGFR TKIs, and all of them consistently shown that in real-world data that not all patient can receive second-line osimertinib. So this is Archer 1050 trial. Here, dacomatinib was compared with geftinib, and in dacomatinib, as we can see that second-line therapy was received only 20% of the patients, and only 10% of patients in this group could receive a third-generation TKI. And in geftinib, only 11% of patients could receive a third generation TKI. Similarly, Flora, we have the second line treatment data as well, of which in second line, around 50 to 60% of patients could receive some form of second line therapy after progression on osimertinib, while in EGFR TKI, only 30% of patients could receive second line osimertinib, and only around 20% or 30% of patients could receive some form of second line therapy. So treatment sequencing in advanced EGFR mutated non-small cell lung carcinoma, survival with first line versus second line osimertinib. So this is the sequencing, how to sequence in treatment of metastatic non-small cell lung carcinoma. So if we are giving osimertinib first, then the overall survival will be around 18.9 months. And if on progression, we can go ahead with chemotherapy, and all the patient might be eligible for chemotherapy. If we are giving on the first line, if we are giving standard of care as EGFR TKI in the first line setting, then the survival is approximately around 10 months. And chemotherapy, the second line, we can either go for chemotherapy or osimertinib, and osimertinib would give an additional 10 months post progression. So in these patients, and then those patients who are osimertinib also got progressed, and one third of the patients had T790M mutation, one third patient were T790M negative, but some unknown resistant mutation, and one third of patients could not receive any second line therapy because of low PS, or were put on best supportive care, or died because of disease. So the key message from this Flora study is that osimertinib is the only EGFR TKI which has demonstrated a clinically and statistically significant improvement in overall survival. The Flora trial was the first to demonstrate how an EGFR TKI has translated PFS into an OS benefit. Osimertinib improved OS versus first generation EGFR TKI in untreated EGFR mutated non-small cell lung carcinoma and T790M mutated non-small cell lung carcinoma that had progressed on first line EGFR TKI. Osimertinib is the only EGFR TKI to report statistically significant intracranial efficacy, which is very significant because none of the other TKI could have so much penetration to the across the blood-brain barrier to have have a CNS DFS benefit also. Osimertinib is well tolerated at its recommended dose of 80 mg. Adverse events leading to dose reductions are frequent in the second generation EGFR TKI like afatinib and dacomatinib. Subsequencing cannot be considered the best strategy as almost 70% of patients are not eligible to receive osimertinib in second line. So these data confirm osimertinib as the first line of standard of care is in metastatic EGFR mutated non-small cell lung carcinoma. So now NCCN has also included osimertinib in their treatment list as the first line of therapy in EGFR mutated lung carcinoma having sensitive mutation to osimertinib. Thank you. Hello. I'll be happy to take any questions.
Thank you, Dr. Nitin, for this lucid presentation. So it was wonderful to discuss about management of EGFR mutated metastatic NSCLC. So I just wanted to understand from your perspective that now that we have data from Flora 2 also, where the chemotherapy has been combined with osimertinib and also with the newer molecules like amivantamab and lazertinib coming into the picture. So what is your take into that? Do you think that the osimertinib will continue to hold its supremacy or will it be replaced by amivantamab?
So I think we need more data on that. We don't have an OS data till now regarding amivantamab plus lazertinib, though the trend is towards a better survival. I would still go ahead with giving osimertinib, and definitely if the patient is fit and young and high disease burden, I would like to go ahead with chemotherapy osimertinib combination first line itself. Otherwise, still I think osimertinib stands its hold in treatment of non-small cell lung carcinoma.
Okay, thank you so much. Is there any other
Okay.
questions? So since there are no other questions, so I think we can move forward. So for the last talk, I would like to invite Dr. Shalabh Arora. Is Dr. Shalabh Arora online?
Yeah, hi, Dr. Kapil. I hope I'm audible.
Yeah, you are audible, Dr. Shalabh. So Dr. Shalabh is a consultant medical oncology in Ujala Sigras Hospital, Haldwani. Dr. Shalabh, the topic that has been given to him is overview of lung cancer because of course we have talked about the details, but it's always better to go back to the basics and have a look on the overview of lung cancer. Over to you, Dr. Shalabh.
Right. I'll just share my screen. Just want to confirm that my screen is visible.
Yeah, it's visible.
Right. So thank you for Dr. Kapil and AstraZeneca for giving this opportunity to connect and to share our thoughts. So I'll just basically give an overview of lung cancer and how it is being managed and what are the new things on the horizon. So understanding the burden of lung cancer in India as per Globocan 2020, lung cancer it accounts for 5% of all the cancers, and there are 72,000 cases. It's the fourth most common if you combine both the sexes, but in males, it is the second most common cancer in our country. And more important than this fact that it is the second most important in males, basically, if you look at the mortality trends, for almost all the other cancers, if you see, the incidence and mortality have a 2:1 ratio. But if you look at it for lung cancer, there were 72,000 new cases and more than 66,000 deaths. So most of the cases actually they present with aggressive disease biology, and they have very poor prognosis with the standard therapies that have been in existence all this while. So first we'll look at the investigative tools for staging, how we approach any patient who comes to us with the lung cancer. The essential investigations that you need are, first of all, a bronchoscopy that helps you get the diagnosis. In most of the cases, a good tissue biopsy. Then for the staging, you need a CT chest, bare minimum, that's usually the starting point. But then we follow it up with PET CT to stage the disease in general. And next, you require EBUS or EUS in a lot of cases, especially for mediastinal staging, lymph node sampling. But some cases that might not be you cannot sample them by EBUS. You have to resort to mediastinoscopy. And lastly, an MRI brain, since these lesions don't show up very well on a CT or a PET CT, so a dedicated brain MRI is required as per guidelines. So how we'll first go a little deeper into stage 3 NSCLC, which is a very heterogeneous group in itself. What are the features that suggest that a lymph node that is enlarged on CT might actually be involved? So any lymph nodes more than 10 mm along the short axis is a predictor of malignancy and on a CT scan. But CT alone has a low sensitivity. It tends to miss out a lot of mediastinal lymphadenopathy. You may find it significant. You may think it's significant, but it's actually not. So basically, both the sensitivity and specificity are low. But it does help in selecting appropriate procedure, whether you want to go ahead with a EBUS or probably a mediastinoscopy. Your CT will help you guide that. When you add PET to CT, the sensitivity and specificity improves significantly, but still there is much more room for improvement because you don't want to miss out on cases that have mediastinal lymphadenopathy. You don't want to undertreat them. On the other hand, there could be some patients who are positive on PET, but might not actually be might not be what do you say? They might not be actually positive, and you might overtreat this subset of patients. So when is invasive mediastinal staging needed? It is needed if you have a centrally located tumor more than 3 centimeter, or if there's extensive infiltration of the mediastinum with no evidence of disease anywhere else, if there's only extensive infiltration mediastinum with N1 disease, if you have a bulky N2 on CT, that is almost always positive, and you don't really need invasive confirmation. If you have discrete N2 nodes, then yes, you should consider invasive staging because PET results over here might be quite equivocal. And if you have a normal mediastinum on CT, but you have a discordant results on PET, there is something positive showing up in your PET, then you need to confirm it. But if there is on CT it's normal and PET is negative, then you often don't have to confirm it. You can consider those lymph nodes as negative. So what is the mediastinal staging protocol? Basically, you look at you do a whole body PET CT and you see where is the tumor is, what are the lymph nodes. If your mediastinal lymph nodes are negative on your PET CT, then you look at the clinical probability, whether there is a low probability of clinical of your mediastinal lymph nodes coming out positive, and if that is so, you subject the patient to upfront surgery. But if you have these mixed results on your PET versus like we discussed previously, then you should go for tissue confirmation. And if your mediastinal lymph nodes are negative, only then proceed with surgery. On the other hand, is this clear-cut lymph nodes that you have a mass or bulky lymph nodes. And in this case also, you don't require tissue confirmation. You can straight away go for multimodality treatment. In between, you have these patients who have non-bulky lymphadenopathy. So basically, any of these gray zones, one that is clearly negative or one that is clearly positive, just leaving those two, you do need tissue confirmation by either EBUS or EUS or maybe even a mediastinoscopy. So the therapy in lung cancer has actually evolved significantly over the past couple of decades. Initially, lung cancer was considered a single disease and it was managed as such by surgery. Then came the pathological histological breakdown. We differentiated them as non-small cell versus small cell. And then the non-small cell was further divided into squamous, non-squamous, large cell, and adenos. And now is the era of molecular pathology where you don't describe them by histology, you actually describe them by the driver mutation or by their PDL1 expression or tumor mutational burden. So now we are looking at the disease in a much more rational and biological way rather than a very simplistic view that we had held previously. So the molecular targets in NSCLC, I don't think this needs me to go into detail. It's adenocarcinoma specifically are molecularly very complex. It's not one disease, it is multiple diseases that we were probably wrongly classifying as a single disease so far. And since now there are so many alterations that have been identified, and there are multiple alterations which have FDA approved targeted therapies for so this number is not 7, it's probably going up with each year with further therapies being developed. And this increases the need for molecular testing in NSCLC, and it is indeed the standard of care now, even in early stage, like my colleagues have discussed previously, that you have a good data for adjuvant therapies now after ADAURA and recently the ALINA trial. So now you have adjuvant therapies, and even early stages should have molecular subtyping done. So what are the current guidelines? Again, going back on to stage 3. So, sorry, a limited stage NSCLC. If it is stage 1A, you just do a surgery, and there is no proven benefit of neoadjuvant or adjuvant chemo. For stage 1B or 2A, you have to have a multidisciplinary discussion. For most of these patients, especially if tumors are more than 4 centimeter, you would go for adjuvant chemotherapy. For stage 2B, compulsory, all these patients have to have adjuvant chemotherapy. And 3A and 3B, for these patients, you use a combination of either neoadjuvant or adjuvant chemo or a sequential chemo RT approach, depending on the volume of disease and your surgeon's comfort about operating these cases. There could be 3 results of surgical resection. You have to take into consideration what are the resection margins as well as pathological stage. So early stage R0 resection, you just have to observe. Stage 2B, you have to complete resection. Even after complete resection, you have to give chemotherapy. If it's an incomplete resection, then re-resection plus chemo, or you have to offer them adjuvant chemo radiation. Same goes for stage 3A or 3B. If you incidentally detect that it has been completely resected, then only chemo. But if since this is a high risk subset, if it's R1 or R2 resection, then that mandates adjuvant chemo and radiation. But what is more important is basically, even after initial treatment, more than 50% of these patients with resectable NSCLC, they will have a recurrence. So almost 60% do have a recurrence, and which could be either local or distant recurrence, and hence we need much more things in our armamentarium to support our patients and reduce the risk of recurrence. And then there was this meta-analysis that you reduce the risk of recurrence, you often resort to chemotherapy. Is there any difference whether you do it in the neoadjuvant or adjuvant setting? And the results were almost comparable. Now, significant results were demonstrated in the ADAURA trial, which showed that if you give them 3 years of osimertinib, EGFR mutated NSCLC, completely resected, 3 years of osimertinib significantly reduces the risk of recurrence or death with a hazard ratio of 0.2. So very few oncology drugs do you see such a good separation of curves that you know that the drug is definitely working. And so the targeted therapy is now moving to early stages. Another drugs that have come up in the early stages is adjuvant immunotherapy. So atezolizumab has performed much better than best supportive care in this setting for patients who had PD-L1 positivity. And we can see that such therapies are clearly improving the survival rates in NSCLC. Briefly about the radiation, lung cancer radiation. So there initially the lung cancer radiation was associated with a high incidence of toxicity. Patients were cured, but they were left with a lot of toxicity. But the recent technologies have led to much safer treatment. IMRT, for instance, has shown to improve survival, and it reduces the dose to the adjacent organs like heart, or it reduces the incidence of pneumonitis. And we all know that increasing the dose to the heart, which is in proximity to the lungs, is associated with a higher risk of death. Then other options are stereotactic radiation. So it's very important to understand the difference between stereotactic and IMRT. So stereotactic is basically a much high dose per fraction, 8 to 20 gray per fraction, and 1 to 5 fractions are delivered with 3D target localization. Whereas in IMRT, it's more of a 3D technique where you irradiate much larger areas over conventional using conventional fractions. Now we also have newer techniques, 4D CT planning, image-guided radiation therapy, IGRT, where basically accurate target coverage is made. Then you have adaptive radiation. So essentially, all these newer techniques are leading to smaller target volumes with the lower doses to the non-target organs. You spare a lot of lung, esophagus, and heart, which lie in close proximity to the tumor. The RT techniques, there has been considerable amount of research for stage 3 NSCLC, where the dose escalation will leads to better outcomes. But as you can see in this Kaplan-Meier curve, basically it was shown that higher doses actually lead to inferior survival, and there was no role of adding cetuximab. And now you have even better results when you do this concurrent chemoradiation and then you follow your patients with the adjuvant immunotherapy. So chemo with or without RT is the standard of care in patients after complete resection. After complete resection in patients with stage 3 NSCLC. So here we have this fourth line at the bottom. All your patients with stage 3A or 3B, they should be given adjuvant radiation plus chemo. Now, another practice-changing paper was this Pacific trial, where patients with stage 3 unresectable NSCLC, they underwent concurrent chemoradiation, and after that, the patients were randomized to observation durvalumab versus placebo. And this significantly, there was around a 10% difference in overall survival at the end of 5 years. So a very significant improvement, and hence this is the standard of care now. It improves the OS from a dismal 15 to 20%. It goes all the way up to 43%. The newer emerging treatment paradigms in NSCLC, we already know about targeted therapy, and immunotherapy is also in the adjuvant setting we have discussed. And for immune checkpoint inhibitors, the journey started in 2015 with pembrolizumab being the first drug to be approved in second line NSCLC. And subsequently, we have had much more drugs that have come up. Atezo, Pembro, they have moved to first line. You have durvalumab consolidation, the Pacific study we just discussed. Pembro has moved to first line. And then you have another significant study, the Checkmate 9LA. Basically, first line NSCLC, you just give them 2 cycles of platinum based chemo and then continue with the chemo-free regimen, Nivo plus ipilimumab. Then over the past few years, we have seen antibody drug conjugates enter the treatment landscape in lung cancer. For instance, a TDXD, I think this is a slightly older subset. There's much a slightly older slide set, so there's much more data now available. The Destiny Lung study, and now TDXD, it has shown very significant results in advanced NSCLC. CAR-T cell therapy, again, this is a new era in cancer immunotherapy where you use a lentivirus or a retrovirus uh, to deliver chimeric antigen receptor T cells, which are transfected, and then they go and destroy the cancer cells in vivo. So I think I'll sum it up by saying that the management landscape is changing quite fast in NSCLC. Initially, we had very dismal outcomes, just resect the early stages, for late stages only chemotherapy, and for the intermediate ones CTRT. But now newer therapies have entered the arena and they have a huge potential to improve patient survival. We have targeted therapies moving up into the adjuvant space, and the OS has in the advanced stages, we have already seen that the overall survival has improved significantly for the molecular subtypes that have therapies targeted towards them. And the patient's quality of life has improved significantly because the ease of oral pills over infusions actually makes it much easier for the patients to be compliant. They can just visit their oncologist once in a couple of months or 3 months and just continue taking an oral pill. And pulmonologist will play a huge role in early diagnosis. I think that is where we need to tap, catch our cases early and then give them the standard of care. And it is very important to involve our pulmonologists in NSCLC tumor boards because they end up dealing with a lot of toxicity that happens after the treatment is over. So I think I'll stop here and I'll stop sharing my screen. If there are any questions. Yeah, I guess no questions. So over to Dr. Kapil.
Thank you, Dr. Sharaf, for the lucid presentation. So I hope by this talk we all learned a lot. Now, we have approached the end of this symposium. So I want to thank all the speakers and all the attendees. I'm sure all of us had something to learn from this topic, and in future also, as the medical oncology advances, new researches come up, it's very, very important for us to gather for such kind of symposium and webinars so that all of us can deliver the best quality of treatment to our patient with the latest evidence ahead. So with this, I want to thank you all once again for keep taking time out of your busy schedule and to participate in this webinar. Good night, everyone. Over to organizers.
Thank you so much, everyone, for joining. Technical
Good.
team, please close the meeting.